Hi, everyone. Welcome to the Center for Health Design's Evidence-Based Design Journal Club today. I am your host, Sheila Bosch, and just remembered I needed to switch the slide. Okay, there we go. And I have the privilege of working with Gresham Smith and Partners as the Director of Research, and what I really do is try to promote our evidence-based design research, original research, and applying it as well in the design process, and all of course in the hopes of improving efficiency, safety, and other health-related outcomes. Now, I really want to welcome you today if you are a first-time visitor on the Evidence-Based Design Journal Club. If you're not too familiar, really the purpose of the Journal Club is for us to engage folks that are involved in healthcare design in a dialogue to understand some of the important research that's been going on, and then really to take that and apply it in your work, in practice. Now, I'm going to do a little bit of housekeeping here. First of all, we are able to offer continuing education units, both AIA and EDAC, and to receive credit for your participation, you can download the forms at any time by just clicking on the Show My Library icon, which is located in the top toolbar where the red arrow is pointing. And you also have access to the AIA quiz, the EDAC CEU form, and today's presentation slides. To download a file, just click on the green arrow next to the file, and when you're finished, click the double right arrow in the top left corner of the media library. The library will close, and the slides will refill that empty space. Now, for EDAC credit, you'll fill out the form, and you'll submit it to CASA Worldwide at the time of your renewal. And for AIA credit, we just need you to take the verification quiz and purchase the CEU management fee for $10 from the CHD store. And Shannon Reckline will take care of that for you. And you can find Shannon's email address on that form as well. Now, let's talk about how to use this. So we really want to have an engaged, active, interactive dialogue going today. And I encourage you to type your questions in the chat box under All. There's an All tab so that everyone can see your questions, and basically you just type your question in there, and as it comes to you, and I'll do my best to have Deborah address those as we go along. There'll also be some Q&A time at the end if you do prefer to wait until the end. So I am really excited to introduce our guest author today, Deborah Harris. Dr. Harris is the president and CEO of RAD Consultants, and she focuses on evidence-based design, strategic planning, programming, design, and research, and her background is rooted in healthcare facility design and health systems planning and policy, and Deborah specializes in the healthcare facility design and assimilating research into evidence-based strategies. Her publications, which are numerous, focus on factors that affect patients, families, and healthcare workers, including patient outcomes, infection prevention, the user experience, building performance, and the all-important cost implications of the physical environment. So, Deborah, thank you for being with us.
Well, thank you. I'm glad to be here.
All right. Now, as I mentioned, we are hosting this event to really identify everyday practical applications of research findings in a published article. And today's article is called The Role of Flooring as a Design Element Affecting Patient and Healthcare Worker Safety. And this was published in the spring 2013 edition of the Herd Journal. So, Deborah, I just would like to really thank you for delving into this important area of research where really there's limited knowledge, which is surprising to me because flooring is such an important product in healthcare facility design. So, I'm actually routinely asked questions about flooring, and of course, it's important, I know, to consider the life cycle costs and the durability and the maintenance and environmental impacts, but perhaps most importantly, safety, which you have addressed here. But it is surprising to me that we really don't know a whole lot about how various types of flooring perform on a number of different kinds of factors. Tell us, what was the impetus that sort of drove you to look into this topic specifically?
Well, I think with the changes in health, that healthcare reform has brought in, and other issues like never events and CMS reimbursement, healthcare systems are really challenged because, some of us have been doing this for a long time, and for healthcare systems to finally address that, the physical environment is having, measurable impacts, it's an important topic to cover.
Absolutely. So, if you will, share with us some of the key concepts sort of behind this literature review, which is a systematic literature review. Tell us more about it.
I think the important thing is, flooring is one of the biggest surfaces we have to cover. It always seems to be a hot topic of debate in terms of what facilities want, need, and what they understand about what products can do to contribute to all of these, variety of factors. The idea was to do a systematic literature review, mainly so that we could sort of coalesce the research that's out there, whether it was literally looking at a flooring or not, and look at those items in a structured process that increases the rigor. It has a well-defined approach. It's comprehensive. It details the methods and synthesizes the studies so that the findings can be used in such a complex decision.
And isn't part of that being systematic, too, is that using your description of how you did this study, that other researchers could replicate this and would probably come to the same sort of conclusions that you did as well?
Right. In fact, systematic literature review, unlike some other literature reviews, is considered empirical research. So it's not just a matter of justifying why you should be working on a particular study or a research question, but really just looking at it and analyzing it in a way where you can put forth a newly analyzed and new conclusions that come from that evidence.
Well, let's talk about the objectives a little bit. But before we talk about the objectives, though, Deborah, if you will, some people on the line may not be that familiar with the term peer review or the peer review process, and I know that you focused on peer-reviewed publications. Can you explain a little bit more about what that means for those who just may not be that familiar?
Sure. When you're looking as a researcher, when you're conducting research and you want to publish, a lot of, you have to decide which route you're going to go. And peer review is really, you submit it to a journal and then they send it out to independent blind reviews. So you may have 3 to 5 reviewers from somewhere in the world who's reviewing your work and just determining whether you do have a clear research design and methodology, that the methodology was implemented and the data was collected correctly, and that you analyzed it and your results are reasonable given all of that, and from their standpoint. And so oftentimes, you go through a review process. Once they accept your paper, they have other recommendations to help make the paper stronger before it goes live or gets published. Competitively, a trade magazine is something that doesn't require peer review. Basically, you can say anything you want to, so the ethics behind it is determined on the writer, and the reader may not be given the information so that they can go back to the source. So when I write, I usually will publish peer review, and then I'll take it to a trade journal because I know that's where a lot of designers and architects are getting their information, and cite the information so that, they will know that it has been, the outcomes that we're talking about are validated, and, try to give it a paper trail that leads back to that peer-reviewed publication.
Yeah, that's exactly the same process I try to follow as well. Now, in this study, you look not only at things like, slips and trips and falls, but you also looked at noise, right? That was part of your objectives, correct?
Well, we did. We looked at infection control. We looked at noise and other things too, like fatigue. And, other issues that may lead to other kinds of outcomes, positive or negative. So all of that is focused, in the article it's broken out between, patient research that's focused on patient outcomes and research that's focused on healthcare worker outcomes.
Well, let's talk first. I really like that you've addressed this, we've talked a little bit. Is there anything else you'd like to say about the methods before we move on?
Sure. Basically, when we define the methodology, the idea is that indeed another researcher could use the same methodology and, find the same, comprehensive list of articles, and then, of course, you can't do this and publish that didn't hit my list. But, the process is, part of it, the method is how you acquire the data and what your inclusion criteria is. And part of it is the execution of the analysis and how you determine whether, even if it makes a cursory inclusion because it's the right topic and it hits the right buttons, is it executed well, where the analysis is strong enough that the conclusions that are made are, have the kind of power that we want it to have in order to use it as a design, to inform design.
Well, one thing I really like that you did is you addressed an approach to ranking the level of the evidence, so looking a bit at the quality. There have been, some other works that have looked at this topic. Ellen Taylor at the Center for Health Design recently published a paper looking at this topic. Tell us a little bit about how you came up with this ranking of evidence process that you developed.
Well, this is a pretty simple ranking, and it really only focused on the research design. And then the analysis part of the systematic literature review really dug into the quality of the research and the strength of the findings. But as far as just ranking it in terms of the kind of research design, I looked at 3 citations from people who work. This is what they do. Like, we research healthcare environments. They research research. So, one of those was published in the New England Journal of Medicine. One was in the Journal of Clinical Nursing, and the other one is Epidemiology and Community Health. So those all came from, well-revered public, journals with researchers that you can have confidence in. And I looked at what they were doing and developed like a 4-point rank so that I could just classify the types of research just in a simplistic way for this purpose.
And we have a slide here that shows those 4 different levels. Can you tell us a little bit about what the difference is between the 4?
Right. So the highest ranking is 1, the lowest ranking is 4. So, if you start at the 4th level, then you're looking at theoretical studies where there aren't necessarily outcomes you can hang your hat on, I guess. Descriptive studies that don't rely on any kind of statistical or qualitative method of analysis, case studies, and expert opinion. And then when you get in the next level of ranking, you're looking at non-randomized controlled studies, before and after studies, and there's variances depending on the quality of the methodology as you get through it. This is just for the research design itself. Focus groups, action research, some of the more qualitative methods fall into this category. And then in the second level, you're looking at randomized controlled studies that might have limitations from the methodology, which prevents them from being at the rank of level 1. You have quasi-experimental studies because now you're getting into things that, you can't control everything, and so you know that you're giving up certain things in your research. Most of the work that I do is applied, so I often fall into this number 2 ranking category because anytime you're in a real environment, you can't control anything, and you have to be able to adjust based on what's happening at any given time. And then ranking level number 1 is multi-centered studies and randomized controlled trials. So, for instance, if you had a study and you were implementing a strong, methodology, and you were collecting that data, at 12 hospitals across the country in different regions, that would be a multi-center study. It may or may not be a randomized controlled trial. Juxtaposed to that, you can have randomized controlled trials at multi-center studies, think pharmaceutical research, or you may have a smaller study in one location, but it's a randomized controlled trial, and it allows for this strength and power in the analysis that you wouldn't otherwise have.
Thank you, Deborah. I'd like to go ahead now and talk about some of the findings from your literature review. First, let's talk about the healthcare-associated illness. Definitely a hot topic in healthcare environments. What did you find in the literature about flooring, specifically in regards to the HAIs?
Well, it's interesting. Things have changed somewhat, but generally speaking, flooring is not considered, a major vector of transmission. It can, just like any other surfaces. It's just less likely to. Of course, the CDC published in 2003, their stated opinion on where you can use carpet tiles and how that. I think the slides are changing. How that impacts the design and what you can do. I think maintenance is always a factor. Some hospital systems may make decisions based on whether or not they think their maintenance crew can manage that flooring in terms of its effective cleaning and disinfecting, rather than making a decision based on the benefits of the flooring, which can vary depending on what your priorities are. And also there's new disinfecting processes that I think is a game changer, because you look at something like hydrogen peroxide, which can decontaminate or disinfect a three-dimensional object. All of a sudden, just trying to clean a flat surface isn't the only option available anymore.
Now, can carpets stand up to these new cleaning methods like the hydrogen peroxide?
Yes. I know that most manufacturers are testing their products now. But when you look at, technology has changed in something like flooring and what we specify over the years and the materials that they use to make it. So when you're looking at these different materials, they're not being affected by hydrogen peroxide. It's a great disinfectant, but it's a pretty benign substance. So it does not harm materials out there.
Let's move on to the topic of patient falls. And actually, just for those who may not be familiar, can you fill us in on sort of the changes that occurred in 2008 regarding healthcare acquired conditions with respect to falls, and how that sort of affects the level of importance? Not only do falls cause tremendous problems for the patients, but it's also now problematic for the hospitals because of the reimbursement structure. Can you tell us a little bit about that?
Sure. Patient fall falls into that category of never events, something that should never happen. And CMS came out in October of 2008 and said, we're not paying for that anymore. You can't have someone fall in your facility and then charge up for the cost of you providing care for them to recover from it. And then all the insurance companies piped up and said, me too, me too. So now there's a huge incentive for healthcare organizations to reduce falls in their facilities and the injuries that come with them, because basically they're at task to pay for the recovery for that. So, in this case, we have, falls account for $3.6 billion annually in healthcare environments. That there's risk of harm to the resident, increased length of stay, and cost to the healthcare organization. It affects, when they're reviewed in terms of reimbursement rates. That's a mitigating factor in terms of whether or not they will hit their reimbursement rate, the benchmark for that. Some of the other research that came from the search looked at, the fact that 70% of falls occur in patient rooms, 15% in bathrooms. I think those numbers are a little, squishy, because my guess is injuries that don't require medical attention, or falls that don't require medical attention, may not be reported the same way that those that require other attention for recovery. Other research that came from this was looking at fractures, because certain kinds of fractures can determine life expectancy, and it certainly determines length of stay and the cost of care and the toll that takes on a patient, especially elderly patients. So a risk from a fracture resulting from a fall on carpet was significantly lower compared to other floor types in one study in 2004. Other people have done other kinds of research similar to this that shows that impact force reduction really does improve, the risk of injury associated with falls. And, the other piece, if you look at the bottom of the slide, is the floor finish factor. So, we're all challenged with, do we have a flooring finish? And, we think that if you have, vinyl that doesn't require wax, you're good to go. But you start looking at other products like rubber and, linoleum and all these other things, and oftentimes over the course of installing these materials, they become dissatisfied with the aesthetic of it, and a lot of times I go into facilities and I'll find very shiny looking floors where you would never expect them to be. And in one study that we conducted, nurses were 2 times more likely to assess a patient at a risk for falling when they were assigned to a patient room that had vinyl flooring than if they were assigned to on the same unit to a room with carpet tiles. So, subjectively, these nurses are in their mind, apparently looking at, wow, they're at a risk for fall. They could slip or trip or fall, and if they fall, they're going to hit that surface. And, this was based on risk of falling assessments that every patient has to go through before they're assigned a patient room.
something else you just made me think about, Deborah, is another study you had conducted previously. They didn't look specifically at falls, but we do know that if there is someone with the patient, like a family member, for instance, there may be a reduced risk of falling because they're going to get the help that they need, theoretically. But you also looked at a study in flooring and about looking at carpet and non-carpeted rooms and family presence. Could you just tell us a little bit about that?
Right. Social support is linked to length of stay. It's linked to, mitigation of some of these other negative events that might occur, like falling. And so we did a behavior mapping study that looked at these rooms that had vinyl and rooms that had carpet tile in them. And we tracked visitors and how long they stayed there. And what we found was there was a statistically significant difference in the amount of time that visitors stayed with their loved ones in rooms that had carpet compared to rooms that had vinyl. So if you're looking at all of those little, all those little nuggets of, the little trail that you build and say, well, if you can create an environment that encourages social support or family presence, and those things have been shown to, decrease length of stay, reduce the risk of falling. Maybe a patient might say, I'm going to get up and go to the restroom, whereas they should be calling a nurse to come assist them. But if they have a family present there, that family can assist them or call for a nurse to find out if that's, an appropriate thing for that patient to do. And so that's kind of the idea behind that family presence and how it contributes.
And something else that comes to mind looking at your last bullet here is this whole idea of glare. And as our population is aging, it's more and more important that we not have glare on the floors for older adults and people with, who have special needs perhaps too. So that's another benefit of the non-shiny floors.
Right. Well, and if you're shining up, if there's a reflected glare can be a problem. If you're putting a topical treatment, you're also reducing the coefficient of friction, which creates a problem for slips.
Now, usually when we think of falls in a hospital, we almost immediately think of patient falls. Yet, you also looked and found some research around healthcare worker falls.
Right. Well, it's interesting because when you look at the NIOSH data, more healthcare workers are injured than workers in construction and mining combined. I mean, we think about construction and mining being these, really dangerous jobs, and in fact they really are. But it's kind of crazy because we have a real problem in keeping healthcare workers safe and healthy so that they can contribute to the quality of care that we want to have in our healthcare facilities. So, slips, trips, and falls account for the largest proportion of lost time injuries to healthcare workers. It's but often, we think about nurses and, lower back injuries and trying to relocate a patient in a bed or trying to move a patient off a bed into a wheelchair or on a gurney and then getting the gurney down. We think about all of that, and in fact, that has been studied and has important things to contribute to. But oftentimes it's that back of house staff that we don't really see all the time that are at higher risk of injury because they're moving huge dining carts and they're doing all the heavy lifting. And there are a lot fewer studies about those guys. But I think it's really important for us to kind of give even time and look at how we can keep those guys healthy too. When you do look at transporting patients or medical equipment, there's a couple of different things. There's that push-pull effect. There's also, whether or not a nurse or another kind of healthcare worker can, use their body and leverage, whether they're trying to lift someone or push a cart or a gurney with a patient on it. And then that's where traction, you need a clear space so that they can position themselves the way they best need to be, but you also need to have that coefficient of friction so that they're not slipping and they can get traction on the floor to do what they're trying to accomplish.
Question coming in. Just can you clarify for the audience what NIOSH stands for?
National Institute of Occupational Safety and Health. It is a government agency. You can also, a lot of times if you're looking at CDC website and you look down all the way at the bottom, they are generating a lot of the data that goes into the CDC website with their data.
Now, another really important topic is this issue of noise. Noise, of course, disrupts patients. Sleep, it can distract nurses from their job, make them feel more tired. What were some of the findings from your literature review?
Well, the one thing that all could agree on is that it's way more noisy in these units than it should be, or what the recommended standards suggest for different areas in the hospital. We also know that noise exposure affects, stress, sleep deprivation, sensory overload, and reduced comfort for patients. Healthcare workers, it limits their communication. It creates distractions that can influence, medication errors or something else slipping through the cracks. It has an effect on cognitive performance and concentration and fatigue. So if you have that, and when you think about it, you look at OSHA, right, and they set these standards for exposure, length of time of exposure at certain levels of sound, and everybody there gets the safety equipment and all of that to help keep them from taking this barrage of sound that's constantly thrown at them. Yet when you look at the average sound level in a hospital, nobody's wearing safety equipment to protect them from that, but they may be on 12-hour shifts being exposed to that. So it does contribute to fatigue. Oftentimes in research, even though flooring's not being looked at as a variable, it often ends up in their recommendations from the researchers conducting these studies. And I find that kind of interesting because you shouldn't be making recommendations about something that's not part of your study, but I think that, level-headed objectivity wins out and people can't help themselves but make those recommendations. And, the other thing is I think it's really important from a sound standpoint to consider that it's not, we're talking about flooring and safety today. But if you look at an environment and you say, you can reduce ambient sound levels by, up to 4 decibels by using a certain flooring, and you can get another 2 decibels from the ceiling tiles. And what else we can help silence these alarms that we don't need all the time, or translate that information a different way. There's a holistic approach to trying to minimize that sound exposure that would be best for patients and healthcare employees. Well,
you just made me think of another thing. I know that have been working on another study. A lot of folks will specify rubber flooring in NICU, for instance, in order to reduce the sound, but can you give us a little sneak peek about what you found with respect to rubber flooring and noise?
Sure. I recently completed a study funded by Mohawk, and we looked at 3 flooring types. Their existing flooring type was terrazzo. We looked at rubber, and then we looked at carpet tile. And basically we were looking at flooring in the corridor for a project that, they were building a replacement facility. And, what we did was we had 3 sound meters, one in the corridor outside of the nurse's station, and then one down each wing of the floor of the hospital. And we collected 42 weeks of sound data over these 3 periods of time. And at each stage, once each phase closed and we downloaded the data, we also had the HCAP scores for the patients, specifically related to the question, how often is the room or the area around your room quiet at night? And we also had survey data from the nurses and that looked at noise and its impacts, and also hip and knee pain related to the underfoot comfort of the floor that was during that phase. And what we found was that there was a significant difference in the ambient sound level in the room with the carpet tile. But strangely enough, the terrazzo floor actually did better than the rubber for sound levels. And I think it's because they ended up waxing the rubber floor, which, rubber is a pretty dense product, but it also, once you seal it off, you're eliminating all the benefits of, what you're talking about, because you're creating, in effect, a reflective surface. And the terrazzo had not been maintained because they knew that they were moving to a new facility, and it tended to have holes in it. And so when you think about, it's one thing that striking sound is reduced, right, from hitting a soft floor like, either rubber or carpet, but the ambient sound that's occurring in the environment, that sound has to have a place to go to reduce it from the overall sound load in that area.
It really surprises me that terrazzo performed better.
Yeah.
Wow. It's why we need good research like this. We did have a question come in regarding noise with respect to maintenance. So, clearly when we have the VCT, or they're in there waxing with the machines and all, but what about this noise associated with cleaning carpeting? Did you look at that, or has anyone that you know of looked at that?
We did. It was included in the study. We did not limit how the unit was used or how they maintained it or anything. We simply collected one data point every 60 seconds for 42 weeks. And so if they were buffing the floors or vacuuming the floors, or, in one case we had an incident. I'm not sure what it was. It involved something that happened with a patient or a family member on that floor, and I was contacted by the hospital because they wanted my data, and I'm like, but we didn't record what they were doing. We only recorded the sound level. But I could go back to the data and see where that event occurred and see that it really skewed the data, in that period of time for it being louder. That actually was in the carpeted phase, so it didn't affect the overall findings. But, by collecting the data over that period of time, we're able to sort of normalize the data by saying, okay, it didn't matter if they were cleaning it, if there was an incident, if there were carts coming down, if, there was, 10 guests in the waiting room that were noise filled out, regardless of what the nurses are saying or doing. That amount of data helps to mitigate all of those factors in the analysis.
Yeah, it's great that you were able to look at that kind of a time period, really. It's just it's excellent. We have another question, too, from Steve Werner. Hi, Steve. And, a lot of our clients do still, after all these years, think, shiny means clean, and it's sort of been a deterrent to installing rubber floors, which tends to be no wax. But you said you've actually seen people coming in and waxing these rubber floors, right, to even make them shiny. Is there any concern that you're aware of that people, if they install something that is not shiny and clean looking, that it will negatively affect their patient satisfaction scores?
Well, yes, that's a kind of an multi-pronged question. Addressing the shiny means clean bit. I think people install rubber with the idea that it's a no wax, better coefficient of friction, all of these things that's mentioned in the question. But they're dissatisfied with how it looks over time because it scuffs very easily. We had comments from our nurses in that study that basically said even when the cleaner went through and cleaned the floor, it still didn't look clean. You get into having to deal with something that's more design-oriented, which raises the cost in order to have something that aesthetically challenges what you can do with carpet tile. These are different issues that come up. It's interesting. I think that clients are driven to raise those patient satisfaction scores, and we need real solutions. So even though rubber is part of the solution because you don't have that same strike force of sound that you would have, say, on terrazzo or a hard surface floor like that. But you're not going to get the ambient sound absorption that you're going to get with a three-dimensional product like a carpet tile. So I think that there comes a time where everyone has to work with their clients and define what their priorities are, really honestly look at what their priorities are and what their end game is, and then try and define where they want what kind of flooring to best maximize, the benefits of it so that they can reach their goals.
Now, you also looked at the issue of flooring with respect to ergonomics, and I think the first thing that comes to people's minds when I think ergonomics is I've got to have the ergonomically correct chair or the keyboard and so forth. But ergonomics is a much larger field. Can you just describe a little bit more about what that means, the word ergonomics?
Sure. I looked at different definitions of ergonomics, and the one that I landed on that really spoke to me in a broader sense than, say, making sure your chair arm height is located right for using a keyboard, is basically that it covers all aspects of a job, including physical stress and environmental factors, which can affect hearing, vision, general comfort, and health. So with that definition, it's more inclusive. So when you start thinking about, nurses that are on 12-hour shifts or, surgeons that are in the OR on their feet for multiple hours, you say, well, hey, that has an ergonomic impact on those people.
So what did you find in terms of ergonomics and flooring? How are the two related?
Well, it's interesting. If you think back, different things, including, other, standing on the floor or whatever. So we talk about noise can contribute to fatigue. Well, fatigue is a contributing factor to human error. It affects alertness, mood, psychomotor, and cognitive performance. So, when you look at other research, one set of research looked at standing on different flooring types for 4 hours. And what they found was there was no difference. And, I think they looked at, concrete, vinyl. They looked at various kinds of floors that were considered hard, resilient, and then carpet with and without a pad. And what they found was for the first 2 hours, there was no significant difference. But when you start getting into that third hour, different floorings had different effects on fatigue. So, and lower leg and back discomfort. And another study looked at that whole push-pull thing. So when you're trying to push or pull, whether it's a gurney or a, housekeeping cart or whatever it is, they looked at that on different floorings. I know we always get into this whole thing about the rollability and how that is impacted by different kinds of flooring, and people want a certain flooring because they think it's going to be remarkably easier to roll something down the hallway. But these researchers found that there was no significant difference between the push and pull forces based on vinyl and carpet flooring. And then finally, the coefficient of friction contributes to safety by minimizing risk of slipping while repositioning or moving patients. And again, that research to me really spoke to me about when you're back in that patient room and you're helping a patient move from a wheelchair to a bed, or even repositioning them for some kind of treatment, you know, a nurse or a lift team or whoever, they need to be able to, you know, position their bodies so that they're using their legs and their knees and not, you know, risking their lower back for injury. And that coefficient of friction plays a big part in, you know, contributing to them minimizing their risk.
So you've done this excellent systematic review of the literature. What were your primary conclusions after looking at all these studies?
Well, I mean, you know, there is a business case to design for safety. You know, we can, you know, contribute to patient outcomes. Again, you know, it's each of these research studies and topics is a cog in the wheel, right? But you start to build, you know, based on your priorities, you can start to look at that research and build, you know, your wheel based on the factors that are important to you to help you make good decisions. But, you know, if you can reduce, you know, patient length of stay because you've got social support and, you know, you can help, you know, you can reduce risk of falling, which has benefits to that patient and to the cost implications for the healthcare organization. You know, you start to see where you can have real impact based on what you're specifying in these facilities. You know, there are gaps in the literature, and so there is additional research. We think that we know a lot about flooring, and then you get in there and you find out that, you know, wow, there are a lot of gaps and there are a lot of things where you can, there may be research that you're like, well, okay, that study has some flaws. We really need to get in there and look at this in a more astute way. So there's plenty of work to be done out there.
So one of the things I really like that the HERD Journal requires, and one of the most important parts, I think, of these journal club discussions is really how then might we take this information and apply it. So talk a little bit, if you will, about the design implications from the research you conducted.
Well, it's interesting. I do think I must say something really, you know, outlandish here. I think that when you put together there's new cleaning methods that can clean three-dimensional objects like carpet fibers in a carpet, and you can see the benefits, whether it's sound, increased patient satisfaction, comfort, all these things. You could consider, given the fact that these are synthetic products that are cleanable, use carpet in patient rooms. You know, that hydrogen peroxide cleaning may be a game changer for that. I think that that'll be hard for a lot of people to swallow. But in any case, you know, corridors are an excellent way to, you know, to use carpet tiles as a way to influence that. And if you have clients that still don't buy into that and they need a smooth finished flooring, then look at the smooth floorings and determine which ones meet your goal. Like, where's the sound coming from? Is it ambient sound or is it strike force sound on the floor? Like, try and figure out the best solution that you can given the limitations that you're working with. You know, I think that I think a lot of systems underestimate their cleaning crews. I also know that there's research out there that says that, you know, there's a direct correlation between the money that you invest in your housekeeping and environmental services and the quality of the job that gets done. So if people want to get serious about fixing some of these issues, instead of just looking at it from a risk assessment standpoint, they need to look at where they can invest to get the better outcomes. And that's sort of instant gratification if you can fix that disconnect between specifying products and housekeeping.
Well, I think there's definitely a lot of perception on the part of, healthcare workers that, oh, carpet in the patient rooms, it's scary to them. Now, we talked a little bit earlier about how hydrogen peroxide does not damage carpet. Do you know if it has any effect on the color fastness of the carpet? Has that been studied at all?
I don't actually know. It is my understanding that it does not, but I don't have any data to support or refute that. I just don't know.
Okay. Every study is limited with budget and scope and time and all sorts of resources. So talk just a little bit. Oh, I'm sorry. I had another design implications slide. Is there anything here you wanted to touch on before we move on?
Well, I think that, the Harvard study that came out that's referenced in the paper, it really was an interesting study that looked at sources of noise. And so while, carpet in our study did show to be a good absorber of sound, there's, again, you could have that three-dimensional, that sort of all-encompassing holistic approach to look at what are the things on the unit that's creating noise and how can you mitigate that to reduce that sound on the front end. Because other patients are just like neonates. They heal when they're quiet and they're still and they can get rest. And we all know that one of the biggest complaints about being in the hospital is I can't get any sleep. It's too noisy.
Absolutely. So I think the next slide I have here is, in fact, on the limitations. So
right.
You could just talk about that a little bit. That would be helpful.
Sure. Part of our limitations, well, in our methodology, we call that what the criteria was for inclusion. Okay, so we started with that. I think that some of the things that came out of the research that met the inclusion criteria, again, I mentioned it before, is that they were making flooring recommendations when flooring was not a variable that they were investigating or evaluating of any kind, which, I guess is interesting. But, something needs to be done to validate those recommendations to some extent, but we're glad that they're making them. I think that, some of the research, we had the simulated studies, for instance, you have to extrapolate that out, the content, in order to apply it within the healthcare situation. So if it's not done in a controlled environment, or if it's not an applied study, if it's a simulation, then you're one more piece removed. But that doesn't mean that simulated environment is not helpful in helping to define some of the objectives that we were looking at. In some cases, might be argued that our search criteria was too stringent, but we were really trying to, even though we only looked at the 4-point ranking analysis, once we had the article, we then were looking at the quality of the methodology and analysis and how that, related to the strength of the findings. And so by having very strict search criteria, that really, we had to focus on the really important stuff, and so some other things might have fallen away in the process.
I know you, and I have the utmost respect for your work, and I know that you are a researcher full of integrity. I just want to know, though, how do you deal with people who may look at the fact that Mohawk sponsored the research, and Mohawk makes carpet? So how do you deal with that?
Well, it's interesting. Yeah, Mohawk makes carpet. They sell a variety of products, of flooring products. So, in fact, they're not exclusively representing carpet, right, out there. So, in that case, That's one factor. Although I've done research that has been funded by one type of manufacturer or another. The reality is that most research in this country is funded by private entities, not the federal government. So if we want to address these issues in a productive way, then that money has to change hands. And in my situation, I have a contract that my client signed that basically says you do not get to participate in the research design or the development of this research project. You don't get to weigh in on the results. You have to live with what the research says, and you also are giving me permission to publish it in a peer-reviewed journal. So for me, that minimizes my conflict of interest because they're not involved in that process, and they're at an arm's length for that as an independent researcher.
You're absolutely right. Without the private funding for research, I can't imagine how much less we would have available. We have a comment that just came in. One question and one comment. One question is, carpet in patient rooms will be a big game changer. And the question is, are there certain types of patient rooms that might be more or less suitable to the use of carpet?
Sure. I think that the CDC, hold on a second. The CDC, hold on. Sorry about that. The CDC's implementation of the 2003 cleaning practices and specifications. So there's a section in there that literally tells you this is what the CDC thinks about where you can put different kinds of floors. And it wouldn't make sense, for instance, put carpet in a burn unit or in a birthing unit, where there's going to be a lot of fluids going. So there's still areas, it's not a game changer in that, oh, wow, we can just, but, in a typical med-surg unit, where, all of those things are limited. In orthopedic units, there are other areas where you could be benefiting from that. And, without it being, you don't want to add to the risk for the patient, right? So, that would still meet what the CDC says. So, I think that's, I would kind of, look at the CDC and then say, well, we've got these ideas and how does it conform to their recommendations?
We are just about out of time. Deborah and I are available to stay on a few minutes afterwards if there are other questions. And this will be recorded if you need to leave. And let me also just remind you about getting your EDAC and AIA CEUs. There's the information that you'll need to do that. Just download the forms and purchase the AIA CEU management service if you need to do that. Now, if you have colleagues who are really interested in flooring, maybe they're flooring manufacturers or representatives, other design professionals, healthcare owners, but they couldn't join us today, there is a link where you can go and watch this and most all of the past evidence-based design journal clubs. So this is the link where you can go and find that video recording for later use. And I just want to mention also the upcoming Icons and Innovators webinar, which is tomorrow. If you have not heard Michael Murphy, he's an excellent speaker with Mass Design Group. He is the CEO. And he will be talking on the topic of beyond the building. Can architecture improve our health? So I encourage you all to take advantage of that as well. And I just would like to say thank you to the Center for Health Design, to the HERD Journal for making the article available to all of us to review today. If you haven't already subscribed to HERD, I do recommend that you do that. It is an excellent publication and the only one that I'm aware of devoted entirely to research regarding the design of healthcare facilities. So with that, let's see, I think we do have, yes, we have another question, so we're out of time, but we'll continue for those of you who can stay. And the question that came in, a couple of them, one is, how can architects and interior designers get truly non-biased information on the use of flooring when so much of the research is, in fact, funded by manufacturers themselves? So what do you say?
Okay, well, first of all, like I said, most research out there is funded by private funders, not government agencies, and there are biases everywhere. The trick is that you want to be able to trust your researcher. Your researcher needs to identify their biases, and then you go from there. I stake my reputation on the fact that I'm an independent researcher, and I don't really have a dog in that fight. It's for me, I think that there's good things that come out of research. In fact, the study for the sound study that Mohawk funded, the 3 material changes, it's interesting how the results came out, but there were different things that came out in the study that might have been beneficial for one material product or the other. So that's not limited by that, but you have to be careful. Like I wouldn't bank on research done in-house, because then they have truly a conflict of interest in terms of how it comes out, right? It can be influenced by different things.
We have another question, too, that came in regarding the turnover time of a room. So if you had carpet in a patient room, you would then need to add perhaps a step for cleaning that carpet. And, how might that affect the room turnover time? And this person notes that they're actually removing carpet even from the office areas because it's already posing a challenge to them.
Right. It's interesting because everything that I've read indicates that carpet takes less time to turn over a room, even if you're doing a hot water extraction cleaning. And maybe it's the equipment that you have. Maybe there's more productive equipment available now that the turnover time is not as significant as, saying, waxing a floor. When you're doing that big stuff. The rest of it is, you're vacuuming a floor. There's no difference between that and, say, mopping a floor, except on a smooth surface floor, you're kicking up allergens and contaminants, and debris that you wouldn't see kicking up in the air from the floor.
Well, that's something we didn't really talk about is carpet acting as a sink, really, for particulate matter and.
Yeah, typically the research has shown since 1982 to the current year, there have been other researchers, including myself, that have conducted studies that, basically come to the same conclusion that carpet holds stuff out of the air. It kind of works as a filter or a sink where it traps things down that then can be removed with a HEPA filter vacuum, commercial vacuum, and which helps keep it out of the air. So it's one of those things where we're thinking about, well, that shiny floor looks really clean, but really the air around it is not necessarily, because you're kicking up that debris, those contaminants all the time. In response, there's a question here about carpet harboring allergens. Well, as a sink, it's going to harbor all kinds of things until you remove it. But again, those things will be just floating around in the air, ready to be inhaled. If you choose a smooth surface floor. So you really just pick your battles and decide what you're willing to live with.
Well, yes, it'll be interesting. I have seen a lot of hospitals in recent years actually installing carpet in the corridors. I would love to see a study or to do a study where we actually go back and look at these hospitals that have installed carpeting where it might not have traditionally been used. So I think there's a lot more to learn, and I just want to thank you, Deborah, for being with us today, and thank you for all of the great work that you continue to do in the evidence-based design field.
Mm-hmm.
With that, we'll wrap it up. Thanks to all of you for joining us. Bye-bye.
Thank you.